Think for a moment. You're 71 years old. You had a good summer. You walked every morning, you kept up with your grandchildren, you slept through the night without trouble. You go in for your annual physical, routine, nothing dramatic. Your doctor looks you over, says everything seems fine, and then pauses and says, "At your age, there are a few things we should probably check, just to be safe." You nod. Of course, that's what responsible patients do. 3 months later, you are sitting in a specialist's office you have never been in before, facing a procedure, for a condition that was never going to hurt you, because a number on a report set off a chain of events that no one stopped to evaluate. The walks, the grandchildren, the sleep, now organised around appointments. That exact story plays out more often than the medical system likes to admit. It is documented in the literature with a consistency that should be part of every conversation a doctor has with a patient over 70. Almost never is. My name is Dr. Ellis, and this channel exists for one reason: to give adults over 65 the honest, evidence-based information they deserve in plain language, without the hedging and the rushed appointments and the assumptions that you'll just do what you're told. What I'm about to share comes from years of studying what the research actually shows when routine medicine runs without asking whether it still applies to you. And here is the truth that most doctors will not say out loud in the time they have with you. After 70, several of the most common health checkups in this country can cause more harm than the conditions they were designed to catch. Not because medicine is failing, because the math changes when you age, and almost nobody is doing that math out loud in the room with you. Today, I'm walking you through 6 specific checkups I would personally reconsider after 70. I'll tell you why the risk calculation shifts, I'll tell you what I've seen happen to real patients, and at the end, I'll give you a framework you can bring into your next appointment that will change the entire dynamic of that conversation. Stay with me through all 6, because number 4 surprises almost everyone who hears it, including patients who have been getting that checkup for 20 years. And number 6 is the one that almost no one has ever thought to question until it is already too late. Before we get into the 6, I want to know who's watching. Drop your city or your country in the comments right now. I read every single one, and it genuinely shapes how I approach these conversations. Now, before we go further, there is one idea I need you to carry through everything that follows, because without it, the individual checkups won't fully make sense on their own. I call it the intervention threshold shift. When you are 55, screening medicine operates on a straightforward logic. You find something early, you treat it, you potentially add decades of healthy life. The benefit window is long. Your body's tolerance for intervention is high. The math is clean and it consistently favours action. But 3 things change after 70, and they change together. The first is that many conditions found by routine screening in older adults are what the research calls clinically insignificant, meaning they exist, they are detectable, but they will never progress to the point of causing harm in your remaining lifetime. Your body will outlive them, not the other way around. The second is that your physiological tolerance for intervention, surgery, procedures, medication regimens, the physical stress of preparation, declines in ways that are real, documented, and almost never discussed openly before a test is ordered. The same procedure that a 58-year-old walks away from in 10 days can take months from a 74-year-old, and sometimes takes more than months. The third is what I call the cascade. One result triggers a follow-up. The follow-up triggers a referral. The referral leads to a procedure. The procedure produces a complication. And a person who walked into a screening appointment feeling fine is suddenly managing a medical situation that originated entirely from the act of looking. That cascade is not rare. It is the thread running through every checkup I'm about to describe. Keep it in mind as we go through each one. The question is never just what did the test find? It is what will happen next, and is your body in a position to benefit from that? Checkup number 1. Routine thyroid screening in the absence of symptoms. Let me tell you about Margaret. Margaret was 73, a retired school teacher from upstate New York. Sharp as ever, still tutoring students in her neighbourhood 3 afternoons a week. She had no fatigue, no weight changes, no cold intolerance, no symptoms of any kind that touched the thyroid. Her internist added a TSH panel to her annual blood work, almost as an afterthought. Margaret had her doubts when the nurse called with the result, but she didn't want to seem like she was overreacting, so she showed up for the follow-up. That decision set off the cascade. The result came back slightly outside the reference range, not dramatically, Slightly. Her doctor referred her to an endocrinologist. The endocrinologist ordered an ultrasound. The ultrasound found a small nodule. The nodule required a biopsy. The biopsy produced an inconclusive result. She was recommended for a diagnostic thyroidectomy, surgical removal of part of her thyroid to rule out malignancy. Margaret went from feeling completely well to facing thyroid surgery in 11 weeks, all because of a mildly abnormal number on a test that was added to her panel without a specific clinical reason. Here is what the evidence says about that chain of events. Thyroid abnormalities with no outward symptoms are extraordinarily common in adults over 70, present in a substantial portion of the population, and the majority of them are stable, slow progressing, and never symptomatic. The American Thyroid Association does not recommend routine TSH screening in older adults without symptoms, precisely because the downstream consequences of finding borderline values cause more harm than the conditions themselves. Thyroid nodules found incidentally in patients over 70 are overwhelmingly benign and in the majority of cases clinically irrelevant. But once a nodule appears in a report, medicine does not have a mechanism for simply setting it aside. What to do instead? If you have symptoms, unexplained fatigue that is genuinely new, significant weight change without explanation, intolerance to cold or heat, heart palpitations, ask your doctor to check your thyroid. If you have no symptoms, ask specifically what clinical finding is driving this test. That question alone often reframes the conversation. Checkup number 2. Routine abdominal aortic aneurysm screening beyond the recommended window. Abdominal aortic aneurysm screening, a one-time ultrasound, has a specific, well-defined benefit window. Men between 65 and 75 who have ever smoked. Within that window, the evidence supports it. One-time screening in that population reduces aneurysm-related mortality. The problem is what happens when that logic is extended beyond its evidence base. Consider a patient like Harold, 79 years old, retired electrician from Central Ohio, never smoked, no family history, no abdominal symptoms. His new physician ordered an abdominal ultrasound as part of a comprehensive workup. It found a small aortic dilation, not an aneurysm by standard criteria, but at the lower threshold of what some clinicians monitor. Harold was referred to a vascular surgeon. He was told the dilation should be watched with imaging every 6 months. He went home. He stopped booking travel in the spring because he wasn't sure how he'd feel before each scan. He put the appointments on the calendar in red. He called his daughter before every one. His actual health status had not changed at all. For patients outside the defined screening window, women of any age, men who never smoked, anyone over 75 without risk factors, the United States Preventive Services Task Force finds the evidence insufficient to support this test. What to do instead? If you fall within the specific evidence-supported population, one-time screening is appropriate. If you do not, ask your doctor directly what population this screening was validated for and whether you belong to it. Checkup number 3. Routine screening colonoscopy after 75 with no symptoms and no history. I have had this conversation more times than I can count, and every time the patient looks surprised. Because colonoscopy feels like responsible medicine. It feels like the kind of thing you are supposed to keep doing. Let me tell you about Ruth. Ruth was 78, a retired librarian from Tucson. No family history of colon cancer, no blood in her stool, no bowel habit changes of any kind. She had been getting colonoscopies since her early 50s and had never had a significant finding. Her gastroenterologist suggested another. She thought nothing of it. It was simply what she did. The preparation the night before left her severely dehydrated. She ended up in the emergency room before the procedure even happened. The colonoscopy was cancelled. Ruth spent 3 days recovering from a bowel prep. The data says something different. The United States Preventive Services Task Force officially recommends against routine colonoscopy screening in average risk adults over 75. The risk-benefit calculation has shifted by that point. Bowel perforation, a literal tear in the colon wall, occurs in approximately 1 in every 500 colonoscopies. In a 55-year-old, that is a manageable surgical complication. In a 78-year-old, it can mean emergency surgery, extended hospitalization, and a recovery that fundamentally alters their independence. The preparation alone, the bowel clearing process the night before, can push older adults into dangerous dehydration and electrolyte imbalances that are genuinely life-threatening. Meanwhile, the colon cancers most likely to be detected in asymptomatic older adults with no family history are, by and large, slow-growing. Slow enough that in many cases they would never progress to a point of causing harm in a person's remaining years. Let me say that again. Slow enough that the person would die with them, not from them. But once something is found, medicine moves forward. What to do instead? A non-invasive stool-based test, a FIT test or a Cologuard test, can identify genuine warning signs without procedural risk. If you have symptoms, blood in the stool, unexplained bowel habit changes, that changes the calculation entirely. Symptoms are always a reason to be evaluated. Absence of symptoms after 75 with a clean history is a reason to ask whether the procedure itself is the greater risk. Checkup number 4. Routine cardiac stress testing without symptoms. This is the one that most consistently surprises people because it sounds so clinically responsible. You're 73, your doctor says, let's just make sure the heart is keeping up. You walk on a treadmill or receive a medication that temporarily elevates your cardiac workload while a technician monitors the response. It sounds like good preventive medicine. Here is the problem the data reveals. In older adults without symptoms, cardiac stress tests carry false positive rates that reach 40% or higher in certain populations. That means nearly half the abnormal results are not indicating a real problem, but medicine cannot treat an abnormal result as nothing. That result sends you to the next step, a cardiac catheterization. Catheterization means threading a thin tube through your blood vessels, typically through your wrist or groin, directly into your chambers of your heart. It is a significant invasive procedure. Risks include vessel damage, arrhythmia, bleeding complications, and in rare cases, it can trigger the cardiac event it was designed to prevent. If the catheterization finds a partial blockage, which is extremely common in adults over 70, many of whom have zero symptoms, you may be recommended for a stent. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during exertion, no palpitations at rest, routine stress testing is looking for problems in a population where finding and intervening does not consistently help. Ask your doctor about optimizing your modifiable risk factors instead: blood pressure, blood sugar, cholesterol, activity level, and sleep quality. That is where the actual evidence lives. Multiple major clinical trials, including the ischemia trial, found that stenting in patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. Let me say that again. Stents did not improve outcomes over medication. A person walking in the door feeling fine ends up on antiplatelet therapy indefinitely, carrying new risk, not less of it. If you're still with me and getting something from this, take a second and type the number 4 in the comments. It tells me who's here and genuinely paying attention. Checkup number 5. Routine annual mammography for low-risk women over 75. Let me tell you about Carol. Carol was 77, a retired nurse from outside Portland. No family history of breast cancer, no genetic markers, no symptoms of any kind. She had been getting annual mammograms for decades. It was automatic. The scan found a small mass. A biopsy followed, then specialist consultations, then a treatment plan that included radiation. Carol completed the treatment. The tumour, it turned out, had almost certainly been biologically inert, a slow-growing, hormonally dormant mass her body had been quietly containing for years. She would have died with it, not from it. The treatment did not extend her life. The fatigue, the appointments, the fear, those were real. I want to be exact here because this topic demands precision. I am not saying do not screen for cancer. Cancer screening has extended and saved lives, and there are populations for whom continued screening past 75 is absolutely appropriate. What I am saying is that for average risk women over 75 with no symptoms, no family history, and no genetic risk markers, the evidence no longer clearly favours routine annual mammography, and the harms are concrete. Imaging technology today is sensitive enough to detect cancers that are biologically indolent, tiny, slow-growing, dormant tumours that, left alone, would never spread and would never shorten a person's life. You would die with them, not from them. But the word malignancy on a report does not come with a biological classification attached. It triggers the full clinical apparatus: biopsy, specialist consultation, treatment decision, radiation, or surgical planning. Research has found that a meaningful proportion of cancers detected through mammography in women over 70 were clinically insignificant, the kind the USPSTF has specifically examined in its guidance on overdiagnosis, meaning treatment offered no survival benefit and produced only side effects. Consider what that means for a 77-year-old woman going through radiation therapy for a tumour her body had been quietly and permanently containing. The treatment does not help her. The side effects are real. The time and the fear and the disruption are real. What to do instead? If you have a family history, a known genetic marker, dense breast tissue with documented risk factors, or symptoms of any kind, screening remains appropriate and important. If you are average risk with no history and no symptoms, ask your doctor this specific question. Based on my age and risk profile, if screening finds something, what would the realistic treatment pathway look like? And what does the evidence say about whether treatment would extend my life? That question does not end the conversation. It begins the right one. Checkup number 6. Asymptomatic carotid artery ultrasound screening. This is the one that almost no one is questioning, and based on what the research consistently shows, it may be the most consequential of everything I've covered today. A carotid artery ultrasound looks at the large blood vessels in your neck that carry blood to your brain. The premise is intuitive. Find a blockage before it causes a stroke, clear it surgically, protect the brain. The reality is far more complicated, and for patients without symptoms, the documented outcomes tell a story that deserves serious attention. The surgical procedure used to treat a carotid blockage, a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the operation. In older adults with additional health conditions, that risk is higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults without symptoms. No mini strokes, no vision disturbances, no sudden neurological changes, no facial drooping or arm weakness. Their analysis found that in people without symptoms, the risk of surgical harm outweighs the benefit. Here is why this matters specifically. Many people over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been stable for years, silent, causing no symptoms, not progressing. When routine screening finds it, a well-meaning surgeon recommends addressing it. But the procedure to clear a blockage that was never producing symptoms can and sometimes does dislodge a small piece of plaque that travels directly to the brain. The cascade takes over from there. What to do instead? If you have no neurological symptoms and brief ones that resolved count as symptoms, so report them immediately, routine carotid screening is generally not the right investment. The far better investment is in the actual modifiable stroke risk factors. Blood pressure above all others. It remains the single most powerful driver of stroke risk. Blood sugar control, smoking cessation if applicable, atrial fibrillation management, and physical activity. Control those and you are doing more for your stroke risk than a screening ultrasound can offer. Now I want to give you something you can use immediately. Every time a doctor recommends a screening test, especially if you are over 70 and you are currently feeling well, I want you to have these 5 questions with you. Write them down. Put them in your phone. Bring them to every appointment. Question 1. What is the false positive rate of this test in people my age, and what happens if the result comes back abnormal? That question tells you the full path before you step onto it. Question 2. If this test finds something, what are the realistic treatment options for someone at my age and in my current health condition? That forces the conversation toward actual outcomes rather than just findings. Question 3. What is the procedural risk of any treatment we would likely pursue if something were found? Every procedure has a risk profile. You deserve to know it before the test, not after. Question 4. What happens if we monitor this condition rather than treating it immediately? Watchful waiting is a legitimate clinical option for many conditions found in older adults, and it is underutilized. Question 5. What is the most effective, non-invasive intervention available for this condition? Because, as you have seen today, with bone health, heart health, stroke prevention, and thyroid function, Lifestyle modifications and medication often outperform procedural intervention with a fraction of the risk. Any physician who is practicing at the standard the evidence supports will welcome these questions. They will take you more seriously for asking them, and if your doctor makes you feel like a problem for raising them, that is important information. Not about your right to ask, but about whether that physician is the right fit for you. I want to close with this. There is a fundamental difference between medicine that generates findings and medicine that protects the life you are actually living. After 70, the goal of your healthcare should not be to produce more reports. It should be to extend your independence, preserve your energy, protect your ability to do what matters to you, and give you more of the mornings you want. The best physicians I have known understand something that the system does not always reward. That recommending watchful waiting often requires more clinical wisdom than ordering another scan. That doing less, when less is what the evidence supports, is not negligence, it is judgment. You have the right to understand what a test is designed to find. You have the right to know what happens if something is found, and whether what's found would ever be treated. You have the right to ask whether treatment would genuinely improve the life you are living right now, and if no honest answer is available, to walk out of that room without signing anything. Medicine has given us extraordinary tools, but a tool is only beneficial when it is used for the right person at the right moment in the right context. You are that person. You have earned the right to a healthcare experience that is organised around your goals, your values, and your body, not around a checklist. If this gave you a new way to think about your health after 70, please subscribe. I make videos like this every week. Honest, evidence-based, and designed to give you the clarity the system rarely has time to offer. And leave a comment. Have you ever had a routine test lead somewhere you didn't expect? Your experience may be exactly what someone else needs to hear before their next appointment. Take care of yourselves. I'll see you in the next one.